Hello, I'm Dr. Becky Lynn. I'm an OBGYN at St. Louis University here in St. Louis, and I specialize in women's sexual health. So I take care of problems like low libido, painful sex, orgasm difficulties, and today we're really going to focus on a condition known as vaginismus, which can lead to painful sex. I want to introduce you to Megan.
Hi, I am a physical therapist with SSM Health Physical Therapy, and my specialty is really women's health and pelvic health. And as Dr. Lynn indicated, I'm excited to talk about vaginismus because we get to work a lot together when a patient does have a diagnosis of vaginismus.
So let me explain what vaginismus is. It's an involuntary contraction of the pelvic floor musculature that can lead to painful sex. So women with vaginismus many times can't have penetration at all because the muscles that surround the vagina are spasmed. So the vagina is just a long hollow tube and it's surrounded by muscles, and those muscles are the muscles that you use when you do Kegel exercise, and sometimes women can't help it, but those muscles spasm. And very often I hear my patients say he's hitting a wall, he can't get in. Mm-hmm. And many times they've seen several physicians or several providers in the past, and they've been told, oh, just relax, drink a glass of wine. Yeah, it's like the most common response. So I want to ask you, Megan, how you go about treating it with pelvic floor physical therapy.
Yeah, so I think the education and knowledge of it is really important, and that's why I'm grateful that we get to work together, because making sure a patient understands that it's not in their head and that it's not, like you said, a conscious decision, and it usually is something that has been going on for a long period of time. And so recognizing and appreciating the frustration that can come with that, and recognizing and appreciating that this is not something that we're going to power through either. So we really respect what the body's doing and how the patient's feeling, and we start all of the physical therapy externally. And so my sort of mantra is that if we can't get the muscles to let go, you can't stretch a contracted muscle. And so we work a lot on different ways to get those muscles to release, and sometimes that's through diaphragmatic breathing or visualization. Sometimes it's just using a mirror to look at those muscles. Mm-hmm. This is an area of the body we can't see very easily. Mm-hmm. And if it's been something that's painful, it's sort of scary to look at. If we Google, we don't know what normal really is.
Right.
And so we do a lot of education just getting comfortable with the area of the vagina and kind of those surrounding muscles, doing an education of where those muscles are, what Kegel muscles are, what their function is, those kinds of things.
So will you tell us a little bit more about the function of the muscles?
Yeah, so they basically have three primary functions. So one is sphincteric, so they're going to open and close, and they're going to help with bowel and bladder function. And then, of course, sexual function, which we're talking about today. And then the third is really supportive, so kind of holding everything up from the bottom. And that's, internal organs and pelvic organs as well. So it's those three main functions. And the other thing about the muscles is it's not an on or an off. There's a really, varied amount of those muscles working. And so thinking that those muscles are just going to turn off is really not an accurate depiction. It's getting those muscles to sort of turn down a little bit more.
So one way I describe the pelvic floor muscles to my patients is I say, think of like a pelvic bone. You think of a human skeleton and a pelvis, and I describe the pelvic floor musculature as a hammock that supports everything so your organs don't fall out the bottom when you're standing up.
Exactly. A bowl or a hammock.
A bowl, I like that one too.
Yeah, all of those.
Keep that one.
Yeah.
And you mentioned diaphragmatic breathing. Mm-hmm. What does that mean?
Yeah, that's one of my favorite easy techniques, although sometimes not easy in the beginning. Mm-hmm. So diaphragmatic breathing is the diaphragm really kind of sits up high in the rib cage. And when you inhale, naturally that diaphragm is going to come down, and then the coolest part is then the pelvic floor comes down as well. So they really have to work in concert together. But if somebody's having pain, they're not taking big, deep breaths, they're taking short, shallow breaths. So the diaphragm is staying fixed, and oftentimes those pelvic muscles are staying fixed. So sometimes if we can get just somebody doing diaphragmatic breathing, then pelvic floor is automatically going to be moving. The other component of diaphragmatic breathing is when the person inhales, the belly's going to fill with air, and then when the person exhales, their belly's going to kind of fall down. So a lot of times we'll place hands on the tummy, somebody will be laying down on their backs, they're really in a comfortable position, kind of work on belly breathing that way. Sometimes yoga breathing, there's a couple different terms for the same type of breathing.
Sometimes when my patients can't get to pelvic floor physical therapy, I'll recommend yoga. Because they really teach that deep breathing where your tummy rises and then falls. And of course they add flexibility to the pelvis and strength, core strength. I'm a huge fan of yoga. Definitely. And then there was a third thing you said, that you said diaphragmatic breathing, and then what was the third way that you treat?
So just sometimes we'll do visualization, or just even looking at that tissue.
Oh, just looking.
Yeah, exactly. So using a mirror, but sometimes visualizing. You know, if I tell someone to relax the muscles, that's not an effective tool, but if we kind of use connotations like mushy or soft or let go, those tend to have a little bit better connotation than relax. Because of course when someone tells us to relax, the feeling is I am relaxed or I am trying to relax. You know, they don't feel that those muscles are contracting.
So do you ever use, I saw this when I worked at Mizzou, they would put like a little I don't know. Biofeedback. And they measure the tonic contraction, the strength, and then have the patient relax. And then they could see, okay, that's relaxed and this is tense. Do you guys do that?
We do, yeah. So you do, the great thing, especially for patients with any type of pain, but in particular vaginismus, is it's all on the outside. So nothing is inserted. And so we put little stickers on the outside in specific places. And it tells us what's happening with those muscles. And we make it fun. We can have like a flower, you know, something like that. Or it can just be a reading. And you're right, it'll show us kind of, okay, this is what it feels like when your muscles are contracting. And this is when your muscles are let go. And then try to mimic that at home. And we are sometimes able to get home units for people if they find that that's beneficial for them. But that's another kind of tool to get those muscles to let go.
How about dilator use?
Yeah, so I have a love-hate relationship, I think, with dilators. I think they can be very helpful for people, but they have to come with a lot of education.
I totally agree. Never just hand somebody a dilator and say, go home and do this.
And it happens.
I know it happens.
It still happens. And back to my comment earlier about you can't stretch a contracted muscle. You know, if the muscles are still contracted and really firm, it's really hard to insert that dilator. And so we want the dilators to be pain-free, essentially. And the other thing is the muscles are really working on a 3-layer process. So we try to get the outer layers pain-free, mushy, let go first before we work on those inner layers. And if those outer layers are still contracted and still painful, to try to insert something beyond that usually doesn't work as well. So I think dilators can be very helpful, but it's usually later on in treatment.
And so I often recommend dilators, and my little pet peeve about dilators is we're not using them to dilate. And so the way that I describe them is to desensitize in a way. So once you've worked with my patients and helped them relax the pelvic floor musculature, then part of how I manage dilators is I'll, obviously start with the smallest one, gradually move up, and have the patient, not me, have the patient, at home, put the dilator in the vagina in order to desensitize them. That's one thing. And so how I explain that is that it sort of tells the brain that you can have something in the vagina and your muscles can be relaxed and you're not sending pain signals to the brain. And the other thing I've noticed with my patients, and you may do the same, is that it gives them confidence to try to have sex, because the last thing you want to do is say, okay, go try and have penetration, because the natural response is to be like, okay, let's try it. You don't want to do that. So if they know that there's a dilator, a large dilator can sit in the vagina and they can be pain-free, I think it just gives them the confidence to try it.
Yeah, I love the comment you made about desensitization. I think that's important because we sort of think of at least intercourse as being an in and then an out, and we forget there's a lot of movement within that. And so we'll use dilators to kind of work on rotation and and some like slight in and out movements. So because I think sometimes people feel like, okay, it's in, but it hurts when I move.
Right.
And so we try to bridge that gap.
Yeah.
And then I'll often have their partner insert the dilator as they feel comfortable. So sometimes they'll feel no pain when the person themselves inserts the dilator, but when their partner inserts it, they feel more pain. And so that helps bridge the gap for communication, but also just get used to somebody else touching them. So any ways that we can kind of bridge that gap that can sometimes feel really big between, you know, in the clinic with us, and then intimacy and intercourse.
Right. I definitely think it's different when somebody else is doing it, because you lose control. And I think that can make people very, very anxious, because once you lose control, it becomes that much harder to do your deep breaths. So sometimes I will tell my patients that when they actually do try intercourse, to be in control. What I was going to say about control is that when the patient does decide to have intercourse with her partner, I always tell the woman to be in control. So she'll need to be the one to guide the penis into the vagina, or she needs to be on top, because it takes away that anxiety of, okay, I'm out of control. And I think it makes a big difference.
Yeah, that's so true. And I talk a lot about boundaries, and not in like a harmful way, but sort of letting the person that has the pain, the partner that we're working with, is the one setting the boundaries. So if she says, okay, well, we're going to work on touching and desensitizing the external tissue, that's the boundary that she has set. So then there's a mutual expectation of it not progressing further, not feeling like they should progress further. So having those boundary or control conversations from the beginning can be really helpful.
I always learn so much when I talk to you, because we approach the problem from like different angles. So I'm like, oh, I like that. I didn't know that. I never think about the 3 layers of muscles, but that's such a good point.
Yeah, I'm curious what you tell patients about time frame. I get asked that a lot. How long is this going to take?
So here's what this is a very, very, very long process. And I think it's really important to set that expectation. And just having treated vaginismus over the long haul and many, many years, I explain to patients that it's baby steps, that this is not going to go away overnight. And we do like a little progress, a little progress, a little progress. And then most people back up a little bit. And then a little progress and a little progress. Maybe they hit a stumbling block and back up. So it's like baby steps forward, a couple steps back. But eventually I've seen many women get past the vaginismus and be able to have pleasurable sex without pain.
Yeah, and we always do a little cheer when that happens, when we can celebrate success with our patients for sure. But you're right. I mean, it definitely can get better, and it can be successful and pleasurable and a good positive experience. But the time frame, I try to be clear up front that it's different for everybody too.
Yes.
That it can, you know, like you said, certain stages can move faster than others, and there's so many factors that play into it.
And one thing I want to say also before I forget about vaginismus is that it's really important that you see a sexual specialist or a pelvic pain specialist when you get that diagnosis. And the reason is, vaginismus many times, I would say the majority of times, doesn't happen just because. It can be due to a lot of other things. So it can be due to endometriosis, it can be due to interstitial cystitis, irritable bowel syndrome, a history of sexual abuse or trauma, back and hip pain, lack of hormones. So if you have vaginismus, and let's say you find that diagnosis on the internet and you go to pelvic floor physical therapy and nobody's treating the endometriosis or the lack of hormones leading to vaginal dryness, then the vaginismus won't get better completely. So it's really important that you see somebody who has knowledge in vaginismus.
Yeah, I totally agree. And with experience, because again, that's where we hear, when people just don't have the understanding or the experience, that's when we hear the have a glass of wine and comments, which I'd like to think are well-intentioned, but are not as helpful as we would like for them to be.
Or patients get told it's all in their head.
Yeah, that's devastating.
That's the worst. The worst. And I think patients are relieved to know, no, there's a reason you have this. This is not all in your head.
And you're not alone. I mean, we see patients, of Of course, because of HIPAA, we don't necessarily meet them
Right.
or introduce them to each other, but there are so many patients, unfortunately, out there with this same diagnosis, and so it's not as unusual as you would think.
Right. And so one thing that we have is we have a support group for women who either have painful penetration or have never been able to have penetration, because we see that too.
Right.
Women who, once they decided to become sexually active, actually couldn't tolerate any penetration. And talk about terrifying, you know, that what's wrong with me? Why am I broken?
Right.
And we have the support group so that they can join if they want. It's secret, private, but then they realize that they're not alone.
Right.
That this is something that happens and it's not all in their head.
Right.
So,
Like a community.
yep.
Yeah.
Anything else you want to add about vaginismus?
I think that's it.
All right. Well, thank you for tuning in.
Thank you.
And we'll see you soon.